All right, welcome back. We've talked about the basic anatomy and physiology of the airway and ventilatory systems. We've discussed maneuvers for dealing with airway management, starting with our BLS maneuvers and moving all the way through to surgical airways. And now we're going to wrap up with the discussion on ventilation. I assume that you know the basic level approach to ventilation, and that still holds true as an effective tool for paramedics. We're going to add a few ideas here that are new and essential for good paramedic practice, but really it all comes down to the same basic idea. Good ventilation at the basic level will save your patients. So with just ventilation in mind, let's look at the rule of twos. And the rule of twos is actually, should receive a lot of credit to Dr. Brody and Kathy Kasner for an article they wrote a few years ago covering this approach to ventilation. Ventilation using the rule of twos is a guide to help you identify all of the things necessary for good ventilation, decreasing the risk of gastric insufflation. So when we're looking at the rule of twos, the first rule is to have two people. And for two people, you really want to have one person focusing on ventilation, and that's going to be squeezing the bag, and the other person is holding the mask so that we have a good seal. Without a good seal, your efforts are completely wasted. Now there is a way to hold the mask appropriately with two hands, assuming you have two people. One person's going to use both hands, and they'll take the mask and they're going to open it up, place it on the patient's face, and then hold with their thumbs on the mask and draw the patient's jaw into the mask to hold the seal. So you're doing essentially a jaw thrust and pushing down on the mask at the same time so that you hold an effective seal for ventilation. The other person ventilates with our general ventilation rules. So we want to have two airways in. So of course, this is America. So two airways is essential. If you have a patient that has a gag reflex, two NPAs is appropriate. Having an NPA and an OPA is appropriate. I would say two OPAs is probably a bit of overkill though. So two airways to splint open that airway essentially so that the ventilation through BVM can be effective. We want to use two fingers to hold cricoid pressure, and this becomes a little bit less important at the paramedic level with cricoid pressure because one, it's being kind of downgraded a bit by the American Heart Association. Extra laryngeal manipulation pressure is something that you will use, or burp. And in that, what you're doing is basically collapsing the esophagus with the rigid structure of the trachea so that we can decrease the pathway of air going into the stomach. But probably worth mentioning just right now, because we haven't mentioned it too much before, is going to be a breakaway here, and that's going to be external laryngeal airway manipulation. And the really important way to remember this is burp. So I'm just going to write this out here. Burp. And so burp is a means of moving the trachea, the larynx, into view when ventilating. And the way to do that is to provide backward, upward, rightward pressure. So this is a P. All right. And so what you're doing is the person is placing their fingers, your are or your partner is placing their fingers onto the cricothyroid structure. And what they're going to do is, as you're lifting up and moving the tongue out of the way with the laryngoscope blade, you generally will hold the pressure and move this structure backward, upward, rightward into view. So think about it. You swipe the tongue to the left, you move this to the right, so tongue goes this way, you move the structures this way where there's less tongue, and we should be able to visualize the vocal cords, right? And as we visualize the vocal cords, that pressure is maintained. And what you'll probably do is, since you need to have that, your right hand available to intubate with. You're going to keep your eye on that position, and you're going to tell your partner to put their fingers on the airway and hold it in place. And an even better way to do this is to have your partner put their finger on the airway first, on the laryngeal structure first. You put your right fingers over their fingers. You move it into position. You tell them to hold it, and you take your hand away. That way, in the transition, you don't lose it. And that really will give you the best visualization of an airway, even a difficult airway in a lot of cases, and you're able to pass the tube through. So I'm going to expand on our two fingers, which is really for cricoid pressure, and move it to external laryngeal airway manipulation using BURP as our acronym to remember the movement. We want to have 2 inches of head elevation so that we can get the sniffing position, and this is in the adult. The child is going to get shoulder elevation. 2 seconds of ventilation, and we want to make sure that it's slow and gentle. And remember, really our inspiratory to expiratory ratio is going to be 2 seconds to 3 seconds, a total of 5 seconds, and that over time, over 60 seconds, will give us 12 breaths per minute. And then 2 psi, and this is really just telling us that we need minimum pressure on the bag so that we don't allow for airway to get into the stomach and put pressure upwards on the diaphragm, so we decrease the ventilatory volume, and then it also puts pressure on the vena cava and perhaps the vagus nerve if too much pressure is applied. So oxygenation is different than ventilation because ventilation has to occur for oxygenation, but we need to increase the percentage of oxygen that we're giving our critical patients that will offload into the cell as we go through the 4th Fick principle. So when we're giving oxygen to our patients, there's really one case in which we don't give a lot of oxygen, and that's going to be the case of a AMI. And in a heart attack, generally, most guidelines are telling us that a AMI telling us that we wouldn't want to give oxygen if their O2 sat is 95% or greater, so no O2. But other than that, we give plenty of oxygen to our patients. Remember, it's going to help us with our Fick principles as we're moving forward. And a pitfall is failing to recognize and treat hypoxia in patients. So we assist patients' ventilations and not respirations, right? So again, I don't like respiratory rate, I like ventilatory rate, because what ends up happening is we're mechanically forcing air in, and if it has oxygen connected to it, then we provide ventilation and oxygenation at the same time. So the devices that we have available to assist ventilation. So truly, if we start from basic and we move our way towards advanced, we've got a couple tools, right? So the first tool is going to be our mouth techniques. So mouth to mask, right? Or barriers. Now, not ideal and something we probably don't want to do, but is an option of providing ventilation, right, to our patients. We can also provide ventilation using the BVM. Then we can start moving into other things. We have a means of giving ventilation with perhaps a demand valve. And a demand valve gives oxygen on demand. There's no bag, it's just hooked up directly to the tube. And then we move into our transport ventilators, which we will talk about here. All right. So when we're dealing with the BVM, all ventilation is really going to fall into a couple specific ranges of values and pressure. The first thing I do want to highlight, though, before we kind of ask these questions, is FiO2. FiO2 is going to be the fraction of inspired oxygen, right? And so if we're looking at partial pressures, when we look at partial pressures in gases, we're looking at a gas law. And do you remember which gas law that might be? A hint, it's Heineken's law. Right, so part of that comes from Henry's law, which is going to give us our partial pressure. So you should be able to name the type of gases that are in air, and primarily the gases in air are going to be oxygen. We have CO2, hopefully not much, but we probably have some CO. It's pollution. We have nitrogen floating around and some other elemental gases that are present, but bioavailable, really O2. So if we looked at O2 in the mix of all these other gases, then we would look at its pressure exerted against all these gases, or its percentage, its fraction, right? A percentage is a fraction of that air. So FiO2 is really looking at that. Now, it's not exactly the same, but loosely translated to SaO2, this is the percentage of bound hemoglobin, right? Not the same, but something we would be considerate of. Where you see this value is when we use our oxygen adjunct. So if we use a nasal cannula, anybody remember what percentage of oxygen it can give at its higher range of delivery through, say, 4 liters or so, 4 to 6 liters. So we're going to roughly give about 44% oxygen. So that really means that we're giving 44% FiO2 because they're breathing another 56% of other gases, right? But when we use the BVM, we're providing 100% O2, right? Because it's hooked to a bag, we have a good seal on the face, and we're able to control that. And then obviously the answer here is going to be 2 providers are what we need. Now back to this thing here. If you think back a few weeks ago, we talked about how many milliliters per kilogram are going to be delivered to our patient. So that was going to be based on ideal body weight. And so ideal body weight, if we have that value, we calculate that value based on height, obviously, then we would use ideal body weight times our range of about 6 to 8 milliliters per kilogram, right? That's the range that we're looking for our safety margin, okay? Now there's another thing also on here, and that's going to be PEEP. Positive end expiratory pressure. It comes up in another slide when we talk about ventilators, but some BVMs actually have a PEEP valve. And positive end expiratory pressure is the pressure that the person breathes against. So pressure against exhalation, right? And so that pressure hyperinflates part of the lung so that part of the lung keeps the alveoli open, right? So that's an idea. So you can dial in a PEEP value on some BVMs. A very small operational thing that we need to put in here, but is certainly testable and needs to be aware of, are our sources of oxygen. So we use medical grade oxygen, which has a very high purity and is stored in very specific containers, so it's not mixed with other types of oxygen and mistakenly put onto your truck. So pure oxygen is delivered into these tanks. The tanks have to be tested, and the weak points of the tank are generally right here where this neck is, where the external connection for the valve exits, and this is kind of threaded on the inside and screws in. But if this is fractured, then this becomes a projectile. Gas will escape this way, and this will move that way. Under high pressure, this could certainly kill somebody. So labels and test dates are going to be associated with when it was filled, and if you're in a low volume service, perhaps they may have an expiration date or a date that the tank needs to be reevaluated. There are various sizes, which we'll talk about in just a few minutes, but the M tank is very common inside the ambulance, and then we've got some of our D and E tanks as well. And then obviously, you know this, oxygen is delivered in liters per minute, and that's the flow rate. That's the flow rate out of the valve that connects to our device, right? But that is not the pressure that's inside here, which is measured in PSI. There's a means of calculating how long a tank will last, and so we want to kind of give you some references here. This is really important when you have long transport times and limited amounts of oxygen. Flight medicine is a good example of that. It's also important if you're using high flow O2, a high oxygen mix. It's CPAP for long transport. CPAP is going to keep the airways open, and it uses a lot of oxygen when it's flowing through. It's basically like it's wide open. So we do want to be aware of that. It's 200 PSI is usually the lowest value that some services want. Services I've worked at want no less than 500 PSI, and at that level we change out the tank. All right. Using the pressure and flow rate and a constant, which is here for the cylinder type, we can determine the length of time you can use this tank based on how full it is and what flow rate you're giving, so that it kind of tells us when we're going to have to change out again. So please do be aware of this. Do be aware of this. And I would recommend when you're at your service or on your internship, why don't you just calculate this once or twice just so you have it down based on the cylinder that you're using. Here are our common cylinders that are available. You note that this large cylinder here is probably the one that's strapped to your ambulance, and that's going to be the M. There's two types of M tanks, but the iron tank is the one that's most likely on your truck. There is a large M tank. This is a lot of times seen, and it's aluminum, seen generally in clinics. The E tank is kind of the larger tank that you would probably be carrying, but most commonly you're going to carry a D or a jumbo D tank on your rigs and probably have it strapped to the OOPS bar and all that fun stuff there to keep it from breaking. So this just tells us a little bit about the size of the tank. Regardless of the tank, the PSI that we're most commonly going to fill these to is between 2,000 and 2,200 PSI. So our range of use would be from 500 in most cases down to 2000 or 2200. Some safety reminders: oxygen is a oxidizer, and so its flammability comes from in the presence of fire. It intensifies the fire, especially when it's under high pressure. So there should be no smoking near the cylinder, and if your ambulance catches fire, you do need to make sure you get people away from the ambulance if the oxygen is still inside, so that those oxygen cylinders, when they do explode, and you're evacuating, they don't hurt somebody else, right? Some other ideas: we want to make sure that we're closing the valves when not in use. It's a couple things. One is these oxygen tanks get moved around a lot, and so if the valve is open, it's going to leak. The other thing is if the valves are open, they can accumulate some dirt, and that would be a problem if we start producing oxygen or providing oxygen to our patient with a nasal cannula. Cylinders should always be secured wherever they're present, and you should never put the cylinder in direct line against you, so pointing at you. You want yourself on the side in case it breaks, all right, because then it becomes obviously a projectile. The therapy regulator is the regulator that you attach and has the multi-prong. If you remember the side of the O2 tank, there's one side that has just kind of the divot for the screw, and then another side has this point here and two guide areas, and this is where oxygen escapes with an O-ring placed. So what we're going to do is reduce the flow of that oxygen's pressure from 2,000 psi, depending on what's in the tank, to 50 psi so we can manage. And so 50 psi is a value that you would have exit the regulator on the screw side, right? So where the regulator attaches, there's a further down in line before you get to the nipple that you connect to your oxygen tubing. There's a piece that sticks off that's threaded, and that screw side is going to provide 50 psi. That's where you would hook up your CPAP, ventilator, or inline devices. So let's talk about some of those devices. So there's manually triggered devices, and these are not automated, which means that obviously here's the oxygen connector. The regulator is our threaded piece that I'm talking about, where it's just once it's open, it's 50 psi being provided, flows through, exits. There is some regulation here by the operator where you push this button. When you push the button, air flows. When you stop pushing the button, air doesn't flow. As simple as that. Now, since this is directly in line on the tank, this is 50 psi and it's 100% O2 because this is likely connected to a tube. There are some dangers. Barotrauma could ensue. So your IE time actually changes a little bit when you're using these. So if you're using this device, or if you're using the jet ventilator, instead of going your 2 to 3, you're going to go a little bit longer, 1 to 3, because this rush of air is more than enough to get them the oxygen they need versus the 2. So 1 second is generally what we'll deliver for that. Positive pressure ventilators, or automatic transport ventilators, as they're called, have a few different settings for them and a few different brands. And we're going to look at one specific that you'll see in the paramedic classroom, the Parapac, which is a great device because our field hospital devices, this is the care device. Any of the pre-hospital devices that are ventilators don't utilize energy generally, aside from some battery power. But the energy that's required is all just kind of mechanical by these dials instead of push buttons. And then your oxygen connects to this and provides the flow rates that we needed. So there's different types of ventilators, many different types of ventilators, but some of the common that we'll see are going to be our assist control, aka our CMV, constant mandatory ventilation. So assist control is an old term, but you might see it on some of the ventilators. What they did when they standardized the terminology for vents, continuous mandatory ventilation took the place of that. And what happens with continuous mandatory ventilation, I'm going to move to this side here, you're going to set your tidal volume plus the frequency, which is our kind of parentheses here, our ventilatory rate. You set that and it's defined, and so this breathes for the patient and gives, as you can guess, if we have time and we have volume, this gives a set minute volume to our patient. Now the patient could initiate their own breath. If they initiate their own breath, they're probably going to receive some volume depending on what you have your setting at, but this will still be chunking along at the rate you have set, so their breath didn't really count according to the ventilator. Then there's also intermittent mandatory ventilation. There used to be SIMV as a term, but it's synchronized, but that's gone away because intermittent mandatory ventilation is synchronized. And so what you'll set here is rate and volume, but when the patient takes a breath, it's going to measure the inspiration. So the inspiration here is going to help control the ventilation. So if they're set to take 16 breaths per minute and they take a breath that wasn't initiated by the ventilator, that becomes one of the 16 and it gives it the total volume that was set. So pressure support is something that we would probably have set up. Now PEEP is not a means of utilizing a ventilator. It's essentially a setting that we use on the ventilator to help keep alveoli open. So again, positive end expiratory pressure. And if you really think about it, you know what PEEP is because if you are aware of CPAP, CPAP provides constant PEEP, right? And I don't discuss much on CPAP here because I assume that you've got some of that in your background. I'll just give you the idea that CPAP cannot be utilized on a patient who's unconscious and not breathing. If they're not breathing, this only provides like basically strapping their face to the tank and opening it up. It doesn't provide intermittent ventilation by any means, so it only provides the PEEP, the high flow oxygen that the patient then has to breathe against. But if they're not breathing, this only holds their airway open but doesn't allow for exhalation, which would lead to death. So let's look at a ventilator. It's not often that you get to kind of sit down and look at these things beforehand. So we've got a picture of CPAP on a ventilator as well. So let's go through kind of some of these settings. So this is going to be a Parapac by NewPac. And I don't know the model that's in your classroom, but the settings are virtually the same. So we'll start over here on the left side. So your oxygen tank would connect in the rear here to this device, and so we have this piece here. This is a little kind of rotating ball. It would turn green when high flow O2 is connected to show you that the O2 tank is providing the amount of pressure. It doesn't tell you how much pressure is available in the tank though, so you do need to be aware of that. Down here, this setting here is going to give us our FiO2. FiO2. And most of them have a setting that's 100, some go to 0, others go only to 50, and some means in between. So we're setting the percentage of oxygen the patient gets. Right here, we want to make sure that we're setting a relief alarm pressure. And so this is in centimeters of water, So our best pressure is going to be somewhere around 20 centimeters of water. If you go further than 20 centimeters of water, you increase the risk that we're going to create barotrauma, or if this is like a BVM, the risk that we're going to send oxygen into the stomach. So we generally want to set this somewhere between 30 and 40 for our alarm. And what this will do is when there's high pressure in the system, for a few reasons, as we troubleshoot on the next slide, if there's high pressure in the system, the alarm will sound and you'll know that you need to troubleshoot and fix the pressure before barotrauma occurs. Okay, so this gauge here tells us the pressure that's being provided through the tube, and it's in centimeters of water. And so our range is going to be upwards through to 40. We really want to be around 20, and this will move every time ventilation is administered and then go back down. If it doesn't go back down, if it maintains high, then we probably have either PEEP set or some problem in the tubing. Moving to the next set here, and then of course there's some alarms here, battery, the patient took a spontaneous breath, and then this button here silences alarm, but never silence alarm until you figure out what's wrong with your device. All right. So looking at CPAP setting, you can change this only to flow so that there's no ventilation, and that would give us CPAP. And CPAP here is giving us our range of settings, essentially for PEEP, so our flow setting. So generally PEEP hangs out at about, CPAP hangs out at about 10 millimeters of water. You can set PEEP here independently so that we can use it on the ventilator, and kind of the same range, and the PEEP will be represented somewhere on this device. If we turn this position to off, then the patient is essentially breathing the air that's flowing through. There's no pressure support at all, so it's just kind of open, but without the pressure of CPAP. Here's where we'll do a lot of our work. So I just kind of covered it up, but it does say CMV, right? So what we're doing in CMV is providing ventilation to that patient. So there's two settings. There's going to be frequency, aka ventilatory rate, and then there's going to be our tidal volume. And remember, we calculate our tidal volume based on the patient's size, and our range for tidal volume is probably within 450 to 500, and we got that number by using ideal body weight times our kilograms, and that will tell us how many milliliters we should be giving our patient at the range of 6 to 8 milliliters. All right, so that would give us our tidal volume. So we notice that the colors here on the settings indicate patient size, so it's a little bit more paramedic proof than we would think. So our range for the adult, 8 breaths to about 20 breaths, so that we can set which breath rate we want there. Smart medicine, we would determine what's wrong with our patient. Maybe they need to breathe a little bit faster to blow off that CO2. Maybe they need to retain some CO2 given our patient's condition. The blue area is going to be for children, and then green for infant. Same thing with tidal volume here. So we see our adult range goes up to 1,000, but I would hope that you're not giving your patient 1,000 cc's of tidal volume and blowing them out. So what this means, once these are set, so we've got this patient, they're about 480 or so is what I'm guessing here. They're set at 12, so you can calculate that to get our minute volume, right? So we've got 12 times 480, and that would tell us our volume per minute that we're aiming for. So it seems like a daunting device, but it's very simple. And if you're transporting an intubated patient, you really shouldn't be using a BVM, because again, we've shown that BVM and paramedics and EMTs, we suck at it. So why not use a device that's a little bit more sensitive, can give some alarms if necessary, and we can, essentially get better medicine, and our hands are free to care for the patient. All right, so why don't we use this slide here just to kind of highlight troubleshooting, right? So trouble with the alarms, right? So if your ventilator has a couple different alarms, so one alarm would be running out of O2, so you connect it, O2. But then we have high and low pressure alarms. So let's look at high pressure. So high pressure alarms are going to mean that the ventilator is sensing an increased pressure in the circuit to the patient. And so high pressure alarms a lot of times come from patients breathing against. So let's see. Spontaneous breaths from our patient, right? So maybe they took a breath and they exhaled when the ventilator was trying to send a breath in. That would increase pressure in the circuit or the tube that goes to the patient. 2, patient biting. Patient biting the tube, and if they're biting the tube, then we have decreased the lumen of the circuit that's sending this pressure forward, so pressure will go back to the ventilator and cause a high pressure alarm. And then 3, this is very often kinked tubing. So you see that there's corrugated tubing that runs from your ventilator to the tube, and that tubing could be kinked along the way, and if it's kinked, pressure going out of the ventilator, so here's our vent, here's our patient, pressure going out of the ventilator would go back and increase the pressure and send off that alarm. So troubleshooting, those are the things you look for. Low pressure alarm. Low pressure alarm comes generally from a leak in the system. So one of the most common causes of low pressure is a leak in the system. And that leak in the system could be a hole somewhere, but more commonly this is disconnected along the circuit. So low pressure alarm, you're going to check to make sure it's connected to the vent. You're going to make sure that all your connections along the corrugated tubing and to the actual tube are all connected tightly. If they're loose, then you'll have a leak, and low pressure would be sensed in the circuit. And it's a circuit, so right, like it's a closed kind of system when it's hooked up to your patient. So you want to troubleshoot those things. All right, so a measure of good ventilation is also pulse oximetry. Now, we should never use pulse oximetry on the first time we go to the patient and use it to check heart rate and oxygen saturation in the absence of us physically doing a good physical assessment. So we want to make sure that this is a tool we add to it. But good SpO2 readings, right? If we remember our oxyhemoglobin dissociation curve, our kind of sigmoid position, we have SpO2 here, and we have basically the O2 pressure in the cell is what we're going to probably measure most. And we kind of correlated some of this around AD. So really, the point before we start to decline on our fast roller coaster, woohoo! The point before we start to decline on our fast roller coaster generally equates to somewhere around 92%. And so we like to keep our patients above 90, 92%, up to 100% when possible. And again, to dispel that misguided information that we get from the hospitals for our practice, we should, if a patient needs oxygen, we should be reaching 100% unless they have a heart problem, AMI, as an example, including in our COPD patients, because we're not with them long enough usually to get their O2 sat up to 100%. So high flow O2 on a patient that's down here at, well, I guess I just drew 50, is going to really have a hard time. A lot of oxygen to make that gap to get up to 80, to get up to 92. That's a lot of oxygen. So our COPD patients, even with high flow oxygen, are not likely to get to that range in our care. In the hospital, yes, and that does become a legitimate concern. Device is potentially unreliable if we have decreased blood flow to the heart, to the fingers where we're measuring it, or in cold. Cold temperatures will decrease the ability for its reliability. And then finally, carbon monoxide poisoning will give us 100% because it's only measuring hemoglobin saturation, not to anything in particular. End-tidal CO2 is going to be kind of our final section for this lecture, and it's extremely important that you know what end-tidal CO2 is. You should be using it in supraglottic airways. You should be using the nasal form in a patient that has any type of respiratory complaint, not just in intubation. But it becomes the gold standard in intubation and is a very useful tool for telling us a few different things, which we'll see at the very end of our lecture here. So the first thing to understand is end-tidal CO2. End-tidal CO2, end of tidal volume. And it's measuring carbon dioxide. So this is measuring carbon dioxide at a very specific point in the person's exhalation cycle. And we're looking for ventilatory adequacy, and it will also tell us, not on this list so much, it will correlate to pH of the blood. And it's pretty accurate. If everything else is working, right? If everything else is working, it'll be accurate in telling us whether the patient is acidotic or alkalotic because of the body's response to such things. Oh, excuse me. So we have a couple detector types. We've got digital, which we'll see in just a moment. We've got waveform, digital and waveform, and then colorimetric. And you're probably familiar with colorimetric because this is what you attach to your supraglottic airway and your BVM to confirm placement. Colorimetric is limited because it doesn't give you a wave and it doesn't give you a number, which are useful values for smart medicine. So digital is really looking at capnometry, right? And capnometry equals a number. And then waveform is going to be capnography. And there's a word graph in there. And nometry is a number. So capnography is going to be a waveform. So let's look at how this works. So capnometry hooked up to a tube is going to measure exhaled gas, right? So here's our tube, here's the BVM if we're hooked up, here's our patient. This goes in line. This is telling us our ventilatory rate. This is telling us our end tidal CO2. And oh, by the way, what's our range? 35 to 45 millimeters of mercury. So if we look at this value, that value is appropriate. So when the person exhales, they're going to sense, this device will sense, either through this or through a tube going to another monitor, will sense the CO2 that's being exhaled out of the lungs. And what we're really interested in is the CO2 that's inside the alveoli, right? Because that's telling us more accurately what's in the blood. So if we just kind of look at a crude drawing here, we've got our airway. The end tidal CO2 is going to be on the tube that's out here, and that's where it's measured, okay? So through the mouth into the trachea, these are all conductive regions, right? And we identified that from here to the tube, if we're using intubation, that space, that dead space, is equal to about 150 milliliters, okay? And then down here we have our tidal volume. So gases exchange back and forth here, and CO2 is offloaded. CO2 has to travel through this space to the device to be measured. Now let's think about this. This is the gas we want to know about. We have this entire space to go through. And do you think that there's mixed gases in this area? Of course there are, because if the person were to breathe in, and they breathe in 700 milliliters, 700 milliliters enters the airway, it dissipates, only about 600 milliliters or a little less, maybe 550, makes its way to the alveoli. The rest of this is probably oxygen-laden gas, right? So when the person exhales, they're exhaling through the dead space, the mixed gases, and we're going to measure all of that. So the first part of the breath is all the stuff that's in here. That's the first part of the breath, right? So let's look at that on a waveform. All right, so our graphical waveform is going to show us a baseline. It's going to show us the inspiratory phase and the expiratory phase, as well as using it as a trend for rate. And so here's what the normal end tidal CO2 waveform looks like. So this is one single waveform. Time is going to be our x-axis, and the y-axis is going to be millimeters of mercury as we're measuring, right? Remember our value, 35 to 45. All right, great. So if we're in that value, then we have kind of normal blood chemistry is what we're going to look at, right? So something to be aware of, though, this is not pH, this is CO2. So a concentration of CO2 that's 45 is acidotic, and a concentration below 35 is alkalotic, right? Less of CO2, which is an acid. Okay, so let's look at blood chemistry. blood chemistry is going to be 7.35 to 7.45, but because it's the reverse logarithmic pH, 7.35 is going to be acid, 7.45 will be alkalotic. Okay, oh, excuse me. So we need to keep that in mind. So we're measuring the gas, CO2, which equals acid for us. So more acid means we're acidotic when measuring our end tidal CO2. All right, so you certainly have these phases here that you need to be aware of. But looking at how this works, what ends up happening here is this downstroke. Let's start here. Let's start with D and E. The downstroke at D and E is when the person starts to breathe in, right? We had CO2 leaving the body into the tube, and then the person took a breath in, or we provided a breath. So the CO2 got sucked back in to the airway, right? Sucked back into the airway. So that happened right here. As it sucked back into the airway, the gas goes down and it mixes back into the airway with oxygen and other things. A and B is going to be the initial phase of exhalation. The person is exhaling, but that starts inside the alveoli, right? So as the alveoli are contracting and air is being sent outward from the bottom up to our measuring device, as air is being sent out, we really don't have much of a change here, right? So exhalation ended, it starts here technically. So we start to have a rise in gas because the gas is now less mixed, less mixed, less mixed, more CO2, more CO2, more CO2 because that's what we're measuring. Between B and C, we have our expiratory upslope, and then we end up in a normal capnography waveform, we end up with C to D being our plateau. This area here tells us what was in the alveoli, right? This was dead space air. So this isn't important to us. So we want to measure at the end of that alveolar plateau, right here. That's the point where we have the end of tidal volume, and we measure end tidal CO2. And then gases are mixed again and go through. So this is not super useful through us. A through C is not useful. C to D, the end of D tells us what was in the alveoli. That is assuming, though, that the Fick principles were present, right? And so let's look at how things impact end tidal CO2. Fick principles, right? You remember our Fick principles. 1, ventilation. 2, external respiration. 3, circulation and perfusion, right? And then 4, internal respiration. Okay, if the person's not ventilating, they're not breathing, they're not exhaling, we're not going to be able to measure CO2, right? Because it doesn't leave the body. If there's a problem with external respiration, CO2 may not be leaving the blood into the lungs, which means that it won't be measurable in a reliable form in the end tidal CO2, right? Because the alveolar mix is decreased, and that's what we're trying to measure in end tidal CO2. If there's no circulation, we can't rely on the value because we can't say that if, say, this circulation shows us a value of 28 on our end tidal CO2, it doesn't mean that the person is actually alkalotic. It just means that the acid didn't make it to the device that we're measuring because circulation didn't carry it. We may very well, especially in shock, still be acidotic, which would mean that this is an abnormal value if that's the case. And then certainly we need internal respiration to offload CO2 into the bloodstream to be carried back and exit, right? So all of these things have to be present. So if a patient has a decreased cardiac output, we may not be able to use end tidal CO2 as a reliable value. But it doesn't mean we don't try, right? Because what we'll see on this next slide, look, courtesy of EMS World, we're going to look at a couple different waveforms here, and it kind of tells us if we're keeping in consideration the Fick principles, it tells us a little bit about why these waveforms look the way they do. So first and foremost, remember this is time, right? And this is going to be millimeters of mercury of CO2, all right? So sudden loss of a waveform, good waveform, I like that waveform. If we're on the tube and we get these little squiggly lines, that means that the tube is probably obstructed, right? So if the tube is, if we see this, troubleshooting would mean check the tube and check circulatory function, because this also happens when the person goes into cardiac arrest, right? They're not breathing anymore when we were measuring this. Decreasing end tidal CO2, so the value is decreasing, but we don't have a great waveform, right? So we're seeing this low, 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 low. The ET tube might be not all the way into the trachea, and the cuff might be leaking, or we have a partial obstruction along the way, right? Only allowing for some of the gas to get out there. We can use end tidal CO2 in CPR. And now I know I said Fick principles have to be present for this to be valuable, but when we do CPR, we're relying on Fick principles to be handled by us, right? Chest compression is going to change Fick's principles 2 through 4, and to some degree 1. And if we're ventilating, we're also addressing 1. So in the CPR assessment, we're probably going to see, because perfusion is low, although they're acidotic, perfusion is low, we're going to see a low value, right? And when we're doing CPR, use end tidal CO2 to see if your compressions are effective. End tidal CO2 value of 10 millimeters of mercury is effective CPR. So we shoot for that as a measure of the chest compressions being useful. If they start to dwindle even further, then maybe it's time to switch out the person doing compressions. Now, something happens specifically when we have the return of spontaneous circulation, or combustion as I like to call it. We have our 10 value, 10, 10, 10, and then boom, we shoot up. And our threshold is about 28. If we get to about 26, 28 millimeters of mercury doing CPR, that means something in the body has changed, and it's likely of return of circulation. That could be before you feel a pulse. It's that sensitive. So an amazing thing to use as a value in CPR. This set of waveforms is plateaued, but the plateau is increasing slowly over time. And this is going to be present in, it's called the shark fin, and bronchospasm. So what ends up happening is, because the airways close, it takes longer. They're usually a little bit wider if they're depending on ventilatory rate. It takes longer for that air to get out. Longer for that air to get out. And if it takes longer to get out, it'll probably be a higher CO2 value because they were retaining it and now they're getting rid of it. So shark fin is indicative of bronchospasm in these patients, and may, if the patient is intubated, that may warrant giving the patient albuterol well before you did your next lung sound assessment and didn't catch the bronchospasm. So this could prompt you to do some work. This is less ventilations over time, and you can see we're going past our 45, and that tells us less ventilations over time are hypoventilation, right? So we would expect a higher end tidal CO2 value because they are likely becoming acidotic through a respiratory mechanism. Hyperventilation would show smaller distances between our breaths, more frequent breaths over time, and if we're breathing faster, we would see a decline in their end tidal CO2 because they're blowing off more CO2. Then decreased end tidal CO2, not decreasing but decreased, could be from apnea or sedation. And on the note of sedation, there's a specific waveform that occurs. We've got our waveform, and then right before end tidal CO2, you see a bit of a notch. And this happens specifically when the patient is experiencing sedation, and the degree and the depth of that notch tells us a little bit about how well the medication is working. Finally, a less accurate device, so you can see how much I actually love the capnography. I love the waveform. I think it's valuable. I've seen patients that have changed their waveform because, and this is completely intubated, flying on a vent with multiple drips, a very brittle diabetic. The waveform started to change. Can you guess which way? When the person started to go a little bit hypoglycemic. I hadn't checked their sugar in a little while. I was due for it, but I hadn't yet. And I noticed their waveform trending over time. So which way do you think it went if they were going without sugar? If we go without sugar, we go into what type of metabolism? So inefficient metabolism that is going to create less ATP, more acid created, the person blows it off, or end tidal CO2 value goes up. So as that value went up, I looked at everything, looked at ventilation. I did a full reassessment, checked the sugar, and it had just started to go down on our patient, prompting me to give the patient some sugar. An amazing device, and it's the gold standard of confirmation of your tube. Now, there's also, to get an initial snapshot, perhaps your equipment isn't ready for capnography, we can use our colorimetric device, right? And we would say that it is proper if we have it placed in the correct location, we should get a change from purple to yellow. And yellow equals yes, it's in the place. Now it doesn't give us a number, and the reading is good after about 6 breaths or so through the BVM. You do need to replace that with some other device, preferably a device that can give you a waveform, and realize that if this device gets wet, it is not going to work. So if you connect this to the tube and they vomit right away, and perhaps the tube isn't in the right, well, there's your confirmation the tube's in the wrong spot, vomit comes up the tube, this device is no longer useful. If the device is not sealed in its package anymore, outside condensation will cause it to give false readings. This is table 6 out of chapter 15 for you to review and tell you a little bit about what happens when entitled CO2 values change and associates it with another area. So just remember, in our CPR, we want to make sure that we're getting at least a value of 10 millimeters of mercury of our entitled CO2 so that we know that compressions are effective. If it starts to go down, switch out the person. Even if it's a little early, it's telling you that something is wrong. So if you haven't gotten to your 2 minutes to switch out and that's going down, fix it earlier than you would otherwise. Some considerations in patients that we're dealing with their airway. So we do need to wonder, do we do our airway intervention on scene or en route, and how much of what intervention are we going to utilize? So sometimes it is appropriate and necessary to stay on scene and get a tube. Other times it's appropriate to do it in the back of the ambulance. And so you need to really make some of those considerations. You should never delay transport to put a tube in if basic maneuvers are working and you think, here's the caveat, you think you'll be successful in the truck. Sometimes you may not be successful in the truck because of the environment. Please don't pull over on the side of the road to get a tube if you're very close to the hospital and your BVM maneuvers are working. So think very clearly about what's needed for your patient, and it doesn't mean you don't get a tube on scene. Sometimes you have to, but that's a choice you have to make, and it can't be a standard rule that tubes get done on scene. Okay, so some science behind it. So we do show in multiple studies that our ventilation sucks as providers. It's not just us, it's nurses, it's physicians, and to some degree RTs. And when you're doing the BVM section in your simulations in lab, there will be a time where you're able to see how deep into the lung space you're getting with your BVM. So you'll be able to kind of measure and get a feel for really accurate ventilation. So the question is, how are your ventilation techniques? And you should answer that with, they need work. It doesn't matter how good you think you are. We need to constantly practice BVM because we're just not great at it. A great airway with crappy ventilation causes a lot of problems for our patients. So there's not a lot of evidence that ET tubes will improve patient outcomes when BVM is useful. And there is a lot of evidence starting to mount that we're not good at tubes, unfortunately, in the field. They become dislodged. LMAs may be better. And when we're dealing with our scope of practice, we'll probably see tubes becoming less and less prominent in our airway values. Please do realize that RSI may not actually benefit patients, and so it's part of our projected care, but we need to be very cautious. Remember, you're going to paralyze a person who is breathing and talking probably before you paralyze them, and now you are in complete control of their airway, and if you fail at controlling their airway, the patient has a bad outcome and dies. You were a causative agent to that by giving them paralytic drugs. It is necessary in certain conditions, so don't shy away from it, but realize it's not something you should take lightly. So we're going to kind of have to evaluate multiple different tools when we're dealing with our critical patient, and we need to determine which things are going to be useful. Overly aggressive ventilation, so squeezing the bag too hard and too frequently, is going to increase pressure in the chest if we're assuming it doesn't go to the stomach. And if it increases the lung volume too much, it puts pressure on the vena cava and the heart, and that decreases preload. And as we know, preload is something that is going to be important for afterload, right? So preload decreasing equals decreasing blood pressures. And that's all done by overly aggressively volumation of your patient's lungs, putting pressure on those structures in the chest. So it's a balancing act, not too little and not too much. The guiding principle is that you're going to use the right tool to meet your patient's needs. And very often you want to use the basic tools to the level that they're useful in your patients, and not go always towards the advanced airways unless you think it's needed now, necessary, or needed later. So in summary of all 4 parts of our lecture, good basic management skills are going to be essential. So if you can't BVM well, intubation doesn't matter. When you're using an ET tube, you always need to have a backup plan, including your basic airways and other, perhaps even the crike in case it goes south. We have to fix these things very, very quickly. Aggressive management of the airway does improve patient outcomes as long as the tools match the needs of our patient. All right, good luck.